I'm going to speak briefly about male mortality and testosterone and GLP-1s. And these are my disclosures. You know, the gender differences in mortality and life expectancy vary by country, but one thing for certain is that almost in every country, men die earlier than women. And there's been much said about this. The Commonwealth study came out in 1998 and just really laid it out really clear when I was a practicing family physician. Said men don't go to the doctor, they wait to the last moment, they accept at the urging of their partners. In Russia, that difference is actually 13 years. In the US, it's been 5 years for a long time, and it's not improved at all. And what's behind this male-female gap in life expectancy? Well, we know that men are much riskier. They have higher rates of smoking, heavy drinking, guns. Almost all those who shoot are males. Risk-taking in recreation, dirt bikes, motorcycle, and employment in hazardous occupations. How many times do you see people on the steel beams? They're not women generally, they're men. But my question to all of you is the primary driver of male mortality, poor cardiometabolic health. And it didn't really come to me until I read this paper in JACC, in the Journal of the American College of Cardiology in 2022, which noted that there are worsening trends in this country in cardiometabolic health, specifically affecting men from 1999 to 2018. In 2017 and 2018, only 6.8% of American adults, men and women, have good cardiometabolic health. And it's a decline in the last 20 years from 7.7%. And disparities exist by age, sex, education, race, and ethnicity. And diet, unhealthy weight gain, poor glucose levels are all worsening over the last 20 years. So we know the optimal levels of cardiometabolic health, and every man who comes into my center gets a waist circumference. But BMI is what's being used day in and day out to measure obesity. But we know there are targets in glucose, lipids, blood pressure. Blood pressure is becoming more aggressive, a clinical disease of cardiovascular disease. We also know that those who have lower educational levels compared to higher educational levels have poor metabolic health. And we know that Latino adults versus white adults or Caucasians have poor metabolic health. There's regional variability of cardiometabolic health, and most of the dementia in this country is related to poor cardiometabolic health and not Alzheimer's disease. We also know that a substantial proportion of incident dementia cases in the US can be attributed to these diseases, and specifically in the southeastern US. And genetic factors aside, what can we do to improve or help men live longer and improve quality of life? Well, we can encourage them to seek medical care, acute and preventative, modify risk factors. That first bullet, though, is a real challenge today because the number of primary care providers are fewer. And trying to get an appointment for an annual physical exam and going in and you no longer get a DRE because it's not acceptable is really kind of disillusioning. So it's really a challenge. Modify risk factors, and we use the atherosclerotic cardiovascular risk assessment tool all the time in my practice. Modify risk behaviors, screen and treat depression, pay attention to family history, diet, exercise, sleep, and weight control are something that I speak to everyone about at every visit. And screening for testosterone deficiency, which is not part of all guidelines, and its comorbidities, and very few providers actually know about the use of PDE5s as cardioprotective medicines, which reduce the risk of cardiovascular events, stroke, MI, and new onset dementia. So let's look at the treatment of obesity with GLP-1s and its synergy, potential synergy with testosterone therapy. Obesity affects everything. We know that. Quality of life, fertility, arthritis, gallstones, coronary disease, cancer, diabetes, high blood pressure. We also know that the projected prevalence of obesity in these blue states, and this is not the political blue states, of course, but it's close to 65%. 65%. We know that even 5 to 10% of weight loss can benefit all of the comorbidities associated with obesity, including reduction and the risk of type 2 diabetes, cardiovascular mortality, lipids, and blood pressure. We know that the treatments of obesity are related to BMI and not waist circumference or visceral adiposity. And we know that drugs are used when men have a BMI in the presence of comorbidities, one comorbidity, one high blood pressure. They have hypertension and their BMI is greater than 25. It's appropriate to give them GLP-1s or SGLT2 inhibitors. We know without comorbidities that they have to be above 30. But everybody is on a low-calorie diet. But we know that BMI is not the best use of a marker for obesity. What we should be looking at is visceral adiposity and waist circumference and not BMI, because BMI comes in all shapes and forms. And there's inflammation and there's inflammation. So the GLP-1s are indicated, like I said, for men with a BMI, because BMI is the basis for prescribing, and one comorbidity, including dyslipidemia, or a BMI of 30 and no comorbidities. And since 2021, these drugs have surpassed or close to surpassing statin therapy for their use in the US. And these are just being glorified as game changers. And you know what? They are game changers. They're amazing. Who wouldn't prefer to have an option at lowering cardiovascular risk, renal failure, dementia via an injection that's painless once a week, that allows you to lose weight, significant weight gradually, versus weight through bariatric surgery? I know if I had that choice, I know what choice I would make. So the point is that all that glitters is not gold. And we don't know everything about GLP-1s yet. We know that they're efficacious. So we also know with diet and exercise that only 20% of obese individuals lose a sufficient amount of weight, i.e. 10%, to improve cardiometabolic health. What very few people know is that all of us have a metabolic set point. Do you know what the metabolic set point is? A patient tells you, I do everything. I eat lettuce. I don't eat anything but lettuce. And you go, oh, really? Yeah, I don't eat anything but lettuce, and my weight never drops below 280 pounds. And this is the way it's been for my whole life. That person cannot get their BMI down below 35. despite all diets. People are not stupid, and they know that what they need to eat. And most will admit to eating for comfort at night, but not everybody does. They're serious about their weight loss. The metabolic set point, the only thing that changes the metabolic set point, and that's your genetics, is the GLP-1. And how it illustrates that change is not known. BMI, like I said, is not the most meaningful metric in obesity medicine, but the GLP-1 is an incretin secreted by L cells in the intestine. And you know, GLP-1s have been out since 2004. What was the first GLP-1? Byetta. Byetta was used in type 2 diabetes and was approved in 2004. No one knew the weight loss ramifications of GLP-1s until 2014, with liraglutide being approved for weight loss. GLP-1s bind to the GLP-1 receptor, expressed in various tissues throughout the body, and exert multiple functions. Many of them are pleomorphic. They regulate appetite and lower glucose through the brain. They increase lipolysis and glucose uptake. They cause peripheral vasodilation and lower blood pressure, just like the PDE5 meds. And they upregulate insulin secretion. Liraglutide was approved for diabetes mellitus in 2006, and Sandexa, which is a form of liraglutide, was approved for weight loss. The cost of liraglutide has not yet come down. It's over $1,000 a month. Semaglutide was approved in 2021 and now has outprescribed atorvastatin. Semaglutide, or Ozempic for diabetes mellitus, or Wegovy for obesity, dulaglutide, which is Trulicity, and tirzepatide, of course, which is Mounjaro or Zepbound. They increase endogenous production of GLP-1, and that promotes insulin secretion, decreases appetite, slows gastric emptying, and increases satiety. Patients eat less and therefore tend to lose weight. The trouble is patients don't eat. When they take these meds, they don't get adequate amounts of protein. And what happens when they don't get adequate amounts of protein? The protein in their bodies the muscle in their bodies starts to be utilized for fuel, and they become or can become sarcopenic. Weight loss is independent of the ability to reduce glucose levels, so these agents don't cause hypoglycemia. They improve cardiovascular outcomes. They reduce MI, stroke, and renal disease. And they're approved for chronic weight management. And we know for anyone with a BMI greater than 27 and one comorbidity. And they were approved for cardiovascular risk reduction in non-diabetics in 2024, and for obstructive sleep apnea in 2025. So the indications and the FDA approval by far exceed the insurance liberalization for these use because of the cost of these medications. And because of that, all of the online therapeutics, which involves some use of the compounding of these drugs, not all compounded GLP-1s are equal, and it's become a tremendous business. They improve semen motility. They improve all semen parameters. They improve gonadotropins and total testosterone levels. I just reviewed a meta-analysis for the Annals of Internal Medicine, which was just about this topic. They improve total testosterone and sexual function or erectile dysfunction. They lessen an individual's appetite for sexual closeness. So potentially they reduce libido. And they improve erectile dysfunction most of the time. This you can see is the axis of their effects on the male reproductive system. But most importantly, these might be the ideal agents for treating the obese male with infertility. And maybe he needs testosterone, or maybe he doesn't if he's hypogonadal. But maybe he needs testosterone for a shorter period of time. And this is where I was talking about the use of the oral agents. In my mind, the use of the oral agents in preserving semen parameters and maintaining levels until they have the significant weight loss over the year and a half might be the way to go in preserving this individual's muscle mass and clinical symptomatology, while at the same time promoting overall better cardiometabolic health. So data support the use of GLP-1s in functional testosterone deficiency in the context of obesity and type 2 diabetes. And it's hypothesized that it's mainly mediated through weight loss, but there's a direct effect on the testes, a direct effect. And weight loss is variable according to the type of GLP-1 receptor agonist, and future studies need to address the differential impact of reproductive health mediated via weight loss as opposed to direct tissue effects. This may have an important role, like I said, in the management of infertility, testosterone deficiency, and ED in obese or diabetic men. This is the STEP paper that led to the approval of semaglutide in 2021. Almost 2,000 adults with a BMI greater than 30 were randomly assigned to semaglutide versus placebo over 68 weeks, and men lost almost 15% of their total body mass. The average weight loss was 6% at 3 months, 12% at 28 weeks, 17.4% at 68 weeks. But most lose up to 35 pounds or more, but it's not overnight. It's over a period of time. And they have to maintain their testosterone levels in between. This is tirzepatide. Tirzepatide at all dosages allowed a significant weight loss, more so than semaglutide. And 5 milligrams, 10 milligrams, 15 milligrams, and placebo. And you can see that the percentage change in body weight from low dose tirzepatide, 5 milligrams to 15 milligrams, was almost 21% at the highest dose. And the amount of individuals who lost more than 25% at week 72 was over 36% of individuals. So the FDA approved semaglutide for cardiovascular risk reduction. We've talked about sarcopenia. Sarcopenia is the gradual loss of muscle mass, strength, and function. It's growing in the US. Sarcopenic obesity happens when people taking GLP-1s don't ingest an adequate amount of protein and don't do resistance training. And a lot of these online companies are not prescribing that. Age blunts anabolic resistance response to muscle protein synthesis. Sedentary behavior, 75% of American adults are sedentary, and that promotes sarcopenia. There's healthy weight loss and there's non-healthy weight loss. And the GLP-1 studies show in their appendices, not in the main papers, that the total loss of fat, of body mass is 49% of lean body mass, 40% of both the STEP and the SUSTAIN studies. Here you see it, semaglutide associated with a fraction lost or gained of lean mass, and the STEP was 45.2% of lean body mass. Also SUSTAIN, 43%, where tirzepatide was associated with a 25% reduction in lean body mass, and liraglutide was associated with a 15% reduction in lean body mass. But the question is, the ideal med for weight loss would not only lose fat, but increase lean body mass. And how much lean body mass loss is acceptable? We don't know. But certainly more than 25% is not acceptable. How do we maintain this lean body mass during use of the GLP-1s? My mind, in men, we should be thinking if they're hypogonadal, whether or not they're clinically symptomatic, they should be on a form of oral testosterone therapy. So the clinical trials regarding BMI are impressive, but not so with body composition. And body composition is a secondary endpoint in all of these studies. It's in the appendices and it's underpowered. So while these cohorts are 2,000 individuals in the STEP and the other studies for approval of these medicines for weight loss, the actual number of people who underwent DEXA scans or MRIs was fewer than 140, because it's all secondary. It's all about safety. So in tirzepatide, again, it was a randomized phase 3 double-blind placebo-controlled trial. The trial included 2,500 participants with a BMI of 30 or more, just what we discussed. Fat mass was reduced by 33 to 36%. Visceral fat mass, specifically the belly, was reduced by 40%, and body weight was reduced by 21%. And lean body mass was closer to 11 to 12%. That's much more acceptable. And it showed that the reduction in fat mass was about 3 times greater than the reduction in lean body mass, resulting in an overall improvement of body composition. The truth is that individuals with obesity have multiple comorbidities, and skeletal muscle changes with GLP-1 meds appear to be adapted and are influenced by age and comorbidities. And for the diabetic older male, tirzepatide may be the drug of choice because it is not associated with as much lean body mass loss. Here we see the comparison, weight loss comparison with caloric restriction, which one can lose about 60% fat and 30% lean mass, and GLP-1 meds, which causes a 25 to 40% lean body mass. And muscle loss in these studies showed loss that all of these drugs were associated with about a 10% loss of muscle mass. And is that acceptable? Is the loss of libido acceptable? Is the FDA examining lean body mass appropriately? Not really. Not really. And the FDA doesn't require any tests of muscle function, mobility, or strength. The mitigation strategies include basically 2: increasing protein intake, specifically 1.7 to 2.2 grams of protein per kilogram per day, and resistance training 2 to 3 times per week of all muscles in the body. The potential benefits of testosterone therapy added to GLP-1 RAs in testosterone deficient men are multiple, and testosterone has been shown to enhance muscle strength and physical function, but we don't have one study yet of testosterone therapy with GLP-1s. Testosterone treatment may improve bone mineral density, which is also vital for overall musculoskeletal health. And combining GLP-1s and testosterone therapy could potentially prevent sarcopenia in obese men. This is the clinical impact. This is one of the only few studies, a very small study of 30 men with obesity-associated hypogonadism, showing the difference between liraglutide and testosterone therapy, and liraglutide and testosterone therapy versus liraglutide alone showed a greater increase in T levels and subjective sexual function. Might this be a more holistic way to maintain men while on their journey to weight reduction? So patients need an individualized approach regarding GLP-1s, not any particular GLP-1, but tirzepatide may be more effective in older diabetic men. Monitoring, they need to be monitored, and muscle mass must be monitored. Exercise and incorporating resistance training is essential to maintain muscle mass. Nutrition, eating your main meal early in the day and eating small amounts of protein several times a day is vital. And what are the potential risks of long-term effects of they have to be considered? I tell every man, we're thinking about, as men live longer, they want two things, and not all of them have to do with their penis. They want to maintain mobility into their 90s. And how many men do you see in their 90s who are not walking with walkers? Very few, very few. Men want to be able to walk in their 90s without a walker, and they want their cognition. And these men, these meds may be an appropriate step together with testosterone therapy to maintain those two goals as men age. So the takeaways are, there's a heterogeneity that exists between specific GLP-1 meds and lean body mass. Exercise, aerobic, and resistance training are vital. Testosterone should be studied in aging men who use GLP-1 meds. Sarcopenia is a chronic disease, underdiagnosed and preventable. And men continue to die earlier than their female counterparts throughout the world. And the principal reason for early male death may be poor cardiometabolic health. And cardiovascular disease and obesity is the most modifiable risk factor for longevity. This, if anybody wants a copy of my slides, this was just in JAMA this summer, but it's a great table to give patients with telling them what nutrients and supplements to take when they use GLP-1s. And I made copies of this for my patients. Okay, I'm all set, and thank you very much.